Thank you, and thank you for all for having me here. So I'm going to try to accomplish a lot of things here, but I do want to start by saying that I think it's critically important to think about this epidemic, this pandemic, as a work in progress. I think that every single day brings us new information as we're moving forward, whether it be about how the disease works or how it's transmitted or how our vaccinations are being rolled out. So, you know, things are moving relatively quickly. So what I have to say today may not be true in a month's time. So we should just keep that in mind. I want to say number two also, to Katya's point, which I really enjoyed your talk, Katya, is that, you know, people behave, but they don't behave out of context. So there is a culture and a context in which people navigate. And, you know, whether that is a political context or it is a, you know, a neighborhood or it is a cultural context, that shapes how people behave. And so that's a lot of what I'm going to talk about today. And just do an overview of where we are with the vaccines and then think about how we're moving these things forward. I have also been actively involved in the last year in lots of different aspects of COVID-19, including the creation of the COVID-19 contact tracing program for the state of New Jersey, and then my own research on life experiences of HIV positive individuals through the COVID-19 pandemic. It's very complicated. It's not clear if there's protection. There seems to be this weird cytokine interaction right now that's causing people's positive people's platelets to like diminish. It's a really, really strange time in the HIV world. A good time, but a strange time with COVID-19. And then also a large scale antibody assessment of using time-based sampling in Newark, looking at exposure to COVID-19 by recruiting people at like supermarkets and bodegas and big box stores, trying to get a better sense of what the pandemic potentially looks like, recognizing the shortcomings of antibodies. And then last but not least, a very large scale national study that we enacted over the course of the spring and the summer on experiences of LGBTQ people around COVID-19. So lots of different aspects of the work. But where are we today? So let me see if I can do this correctly. You're seeing my slides good? Is that okay? Let me actually put it on slideshow and you can see even better. And there we go. So the state of the pandemic. And so where we are right now is, fortunately, in the last few days, in a better place than we were a couple of weeks ago. We saw the Christmas, Hanukkah, Kwanzaa rush of like infections when people gathered. We've seen a decrease in cases, a decrease in deaths, and a decrease in hospitalizations over the course of the last week or so, which is a step in the right direction. We may be coming up for air, but there is no doubt in anybody's mind that at the rate we're going, we will be at 500,000 deaths by the end of February, if not sooner than the end of February. In the state of New Jersey, the pattern is consistent that with the rest of the country. We know that there's a total of about 20,000 confirmed deaths and about 600,000 confirmed cases. So what are we going to do about managing this disease? We spent a lot of time talking about behaviors, about mask wearing, about washing hands, about physically distancing with each other. You know, vaccination is another behavior that we're going to enact. And just like mask wearing, and just like washing hands, and just like physical distancing, vaccination uptake requires that human beings act as rational operators. And we know that human beings are anything but rational operators. And so we're going to have to think about all of the stuff that Katya told us about hesitancy and all of the emotional and psychosocial factors that drive people's behavior to continue to try to get vaccination to a point in our country where we have about 200 million people vaccinated. Without that, we don't get to herd immunity. And quite frankly, I don't think we get to that point of 200 million anytime before the end of the summer. The vaccines, people will say it's our biomedical intervention. I always laugh at that because I'm like, yeah, sure, but they require behavior, like exercise and like wearing a mask, and that people need to do this. The vaccine doesn't just float down from the sky into somebody's arm and all of a sudden it's there. And so thinking about how the behavioral components married with the social and structural and political that Katya talked about, married with the biomedical come together is going to be really key in trying to move this forward. Where are we? So we've got two vaccines right now. We've got the Moderna vaccine, 2 doses, 28 days. The Pfizer vaccine, 2 doses, 21 days. Johnson & Johnson will be heard by the FDA momentarily. probably available by the middle of February. It's a one-dose vaccine. AstraZeneca is potentially a problem. The EU yesterday reported they are unlikely to approve it for age over 65, given the limited efficacy it has shown. And Merck just pulled its vaccines yesterday because of the lack of efficacy of those vaccines. So we've got 3 vaccines, which is potentially by February, which is better than 2 vaccines. We also have it in combination with the Production Act being implemented. And so vaccination is actually being created by suppliers. So hopefully, for those of you who are very patiently waiting, and I know you're very patiently waiting, because I keep getting phone calls from my friends and colleagues because they must think that I have vaccine in the trunk of my car that I'm keeping from them. They keep wanting me to hook them up. I'm like, it's like Studio 54 days, kids here. You have to just wait your turn and maybe you'll get in. But I think in 2 weeks' time, we will actually have sufficient vaccine that we will be able to roll it out to the populations that need it the most. But we are certainly at a standstill in New Jersey. And I don't want to just pinpoint New Jersey, but every state is going through this. And Governor Murphy and Commissioner Persicelli did their darndest to try to get us the vaccine. The problem is that they were blindsided by the federal government. So here's where we are with vaccines right now in the state of New Jersey. Let's say that by the end of this month, 500,000 people are vaccinated. Well, that means that at that rate, in the state of New Jersey, with people over age 18, we need 12 more months to get everybody fully vaccinated. So that means the fall, before we have the majority of people vaccinated. I am hoping that this number of 500,000 will become larger and that 12-month window will become a 6-month window. But then again, that really will depend on the availability of vaccine. You will see at the bottom of the chart there a breakdown of vaccination by gender. Females right now currently much more likely to have been vaccinated than males, and not surprising to anyone here, given the health disparities that we owe. Like, why was anybody shocked that Black and brown people were dying at higher rates from COVID-19? Why did this act like a huge surprise to anyone when Black and brown people suffer health disparities across every disease state? Right? So we were like, oh my God. No, not oh my God. This is exactly what was going to happen in a society that doesn't have social justice and health equity. And we see it here with the vaccination also, with close to half of those people who are vaccinated mostly being white. So there's a disparity there also. So here is what I got in the mail from the state recently, because I am in the 1B group. You are eligible to get the COVID-19 vaccine. However, due to supply limitation, vaccination point may be difficult to forget. So we ask for your continued patience throughout this process. This is the frustration people are feeling. I'm hoping we will be able to get through this quickly so that people who actually are motivated, and there are a lot of people who are motivated to get the vaccination, don't lose that motivation. Okay. Right now in our state, as we know, there is a COVID vaccination registration site that I actually think is pretty good. The problem, of course, is for older adults, such sites are very complicated. And so what we need to think about, and what I want our communications people, our experts to think about, is how we message this to older adults. I've got a phone at 58 years old that I guess I know how to use, but if I was 14, probably would know how to use a lot better. And so I think thinking about how we continue to message to older adults, how we help them being able to register in a way that is amenable to them, that is helpful to them, that doesn't depend that they navigate some complicated system, is really, really going to be absolutely key. I think about this commercial I see on TV all the time where a young girl who's going to her foster mother talking about breaking up with this young man and saying that he tagged her, and the foster mother says, well, I can cut out those tags, right? And the daughter saying that's not how tags really work. So I think in that joke is a reality of where we are with the sort of literacy of people around e-technology. As I said before, we are in phases 1A and 1B right now. I was very happy when Governor Murphy and Commissioner Persicelli, along with Governor Cuomo from my home state of New York, decided to open it up, because I think what was happening is that we were sort of like waiting in line for everybody in 1A to get done before we moved to 1B. And my whole metaphor for that was, that's kind of like being on a ship that's sinking and saying to people, you got to fill up one boat first before you do the other boats, right, to get off the boat. That's not the way to work. We need to open up we need to open it up more widely, and that's what happened. As a result, unfortunately, because I'm going to say it, the Trump administration lied. There wasn't enough vaccine to do that. Had we known that, we might not have opened it up so widely, but who knew at the time? So Fauci says herd immunity could require nearly 90% of the population to get vaccinated. Now that Dr. Fauci can actually speak again, we'll probably be getting a lot more facts on a real-time basis. I think 75 to 80% is probably more realistic, and that will get us to the herd immunity that we need, given the fact that there are some people like me who had a mild version of COVID-19 in March who has this persistent antibodies, right? So that combination with the vaccinations should get us to a decent point. This is a chart looking at a Gallup poll and building on Katya's work about vaccination hesitancy. And fortunately, we have seen an uptick in the willingness of people to receive vaccine. I think that as you change culture and as you change messaging, and as you have a leader in this country who is consistent with the leader in our state, you're going to see much less resistance. There will always be people who are not going to take the vaccine, always, but those people have always existed. We also see this consistent pattern, not only across the population, but across numerous demographics, including age, race, gender, education, party, and income, right? Even the Republicans and people who are leaning Republican have shown an uptick in their willingness to take the vaccination. Of course, there is the opposition, there's the anti-vaxxers, there are people who are resistant to anti-vaxxing, and this is a really wide phenomenon. And, especially in social media, and what we're in one study that was found and that was published, they tracked 425 accounts on Facebook, Instagram, YouTube, and Twitter, and showed that 59 million followers, there were 59 million followers for those particular accounts. And there had been, all of these posts about anti-vaccination just simply during the month of June, right? So there is a lot of misinformation out there that is unfortunately not being regulated. Okay, let me keep going here. So mythologies drive vaccination opposition. We know that perfectly well. We need to understand that we are in this battle, and we need the best tool I think we have is to just continually put out the correct messaging. I've spent way too much of my last few months doing news programs, but I do it because I think that that information just needs to be heard over and over and over again. And the more we repeat it, the in better shape we will be in. Okay. So finally, I think the other challenge we face is that we have a healthcare profession where not everybody's so willing to be vaccinated. And we know from studies that have been published during this year that nurses express much more vaccine hesitancy than doctors. As Katya said, women more vaccine hesitancy than men, although based on the New Jersey data, the vaccine has been taken more by men. People of color, not surprising, given the medical mistrust and mistreatment of people of color throughout the course of the 402 years in this country, are more hesitant. One half of all healthcare workers in 17 Riverside County refuse to be vaccinated. That is a problem. So if the people who are actually delivering the care are hesitating to actually receive the vaccine, then we have a struggle to get those who are not healthcare providers to actually believe in the vaccine. So I think we have a lot of work to do here on multiple fronts. So, but what do we need to think about moving forward? And this is going to be the wrap up of my talk. I think first and foremost, the future holds. I'm thinking about how we improve things and how we move forward. Realizing our national strategy. We have a strategy now. For those of you who don't know, it was not until Obama and Biden in 2010 that we had a national HIV strategy. That just took like 30 years. But fortunately, Biden, learned from that, and he came in with his national COVID strategy. So we have a strategy right now that is real, investing in immunization and enrolling providers and community outreach, which I think is a really, like the HIV plan, really thinks about COVID-19, not from a purely biomedical perspective, but from a biopsychosocial perspective. And that's how we need to think about this disease and every disease. Number two, we need to think about the ongoing role of responsibility and altruism. right? What role do we as human beings have? There are personal responsibilities we have, and there are shared responsibilities. And I have spent the last few months talking about my own personal responsibility and my commitment to my brother. And I say to people, if you are struggling with mask wearing, and let's face it, nobody loves wearing a mask every day, right? This is so reminiscent to me of my work in AIDS in the 80s and 90s. Nobody wants to wear a condom every time. It's the same thing, right? But we do it because we care about other human beings. And for me, the story I always share is about my brother, my younger brother, who has MS. The last thing I want to do is transmit COVID-19 to him. And so think about the person you love the most and enact your responsibility towards that person and towards your humanity at large. Number 3, we need to normalize health behaviors. We need to make it normal that vaccination is part of our fight against this disease. So we need to create habits. We need to identify the environmental constraints. We need to build knowledge. And all of those things in combination can get us to a point where we change behavior. Unless we change people's habit and automatic processes, unless we change the sort of false narrative that exists around COVID-19, the degradation of science that has existed in this country for 4 years and more, right? Unless we make it easy to get the vaccine, which is take it to people, don't expect people to come to you, right? Then we're not going to be actually able to get to the point where we're actually enacting this behavior automatically. Building trustworthiness, expertise, and acceptability, or TEAT, means that we have to target very specifically certain groups that are less likely to be vaccinated, and thinking about what are the strategies we use with those populations to get them to trust, right? And the fact of the matter is one size is not going to fit all here. How we build trust in 65-year-olds may be different than healthcare providers, may be different than Republicans, recognizing that, of course, that people hold multiple intersectional identities, of course, but that just like we would not expect every teacher in a classroom to teach their students, every single student, with one method, that there are multiple methods. We need to use multiple methods, multiple adaptive strategies for interventions to increase hesitancy. And this is just another example, just showing again about the trustworthiness and the concern that people have about side effects and what have you. But again, I have been doing work on HPV vaccination in young sexual minority men. And let me tell you, there are concerns there and misinformation that have a whole generation of young sexual minority men who are not vaccinated for HPV and who are exposed to virulent strains of HPV, because somehow we dropped the ball on that. Number 5, debunking myths and respecting science. So I think that sort of says it all, right? And so, making sure we put the facts out there and making it clear to people with a recognition that we need to say things many, 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 many times in order for the message to become clear. So here are just some 10 things, that I wrote in this editorial that came out in the Hellenic News of America last week that I'm happy to share the link with you, but just trying to put the facts here in as simple, everyday language as possible for people. And again, debunking this idea that somehow these vaccines were just invented overnight. The fact of the matter is that the scientists in the United States have been thinking about SARS since 2003. When the first SARS epidemic happened, and sort of disentangling how SARS manifests. And so these trials, which took place, yes, they were kickstarted for sure, but Project Warp Speed, which turned into Project Snail's Pace. But unfortunately, people just think that they were developed overnight. But the message has to be that we've been thinking about SARS for a long time, and then no shortcuts. There were no shortcuts to the testing. The FDA was really held the scientists, hands to the feet to the fire about making sure that the data were clear. And that's why Merck, for example, pulled its vaccinations. Learn from the past. I mean, how many times do we need to say this? I mean, the same thing, with the same battle we had with polio, the same battle we had with smallpox, the same battle we had with HIV. I wrote this article a few months ago, like lessons from HIV are very much like lessons to talk about COVID-19. The whole hysteria about bags at the supermarket so reminded me of toilet seats from the 80s. It was just like people's behavior has not really changed. Let's use the past to try to maintain the hysteria in the present. And then finally, I'm going to conclude by saying this is an article that I just got published about a new urban public health paradigm. I'm very proud to say that this new urban public health paradigm was selected by President Holloway to be one of the 6 presidential initiatives. My colleague Leslie Cantor and I developed this and have been working on it for several years. But I think ultimately our path forward for this or any disease or any health condition is to build programs around social justice and health equity that marry the efforts of clinical care and public health, and that bring to the table as equal partners the academic health system with government, with business, which knows how to do things a lot better than academia, and with the people who are most affected in the community at the table together, thinking about solutions. And this is the paradigm we're trying to implement in Newark and then provide as a model for the rest of the country. I leave you with these links and what have you to follow me and to find our school. And it's been a pleasure speaking with you this afternoon.